Hi, I'm Tatiana the Doula, and I am continuing on with these notes reading, and now I'm reading the section 3A handout. 3A handout. Influencing the feeding choice. Acknowledging that women don't always have a full spectrum of choices. In the US, public health efforts to increase breastfeeding first relied on romance. We still have romance, but now it's tempered with reality. Then risk. Now people are incorporating strategies from the sociologic perspectives of Solomon Asch. To make breastfeeding the norm, we need to take the first chair. Today, social marketing, technology, and unique campaigns are taking the first chair. Research also tells us that the decision to initiate breastfeeding is influenced more by embodied knowledge, the kind of knowledge gained from seeing breastfeeding, than by gaining theoretical knowledge about its benefits. The decision does not come from prenatal education, neither do behaviors such as exclusive breastfeeding result from education. That providers seem to not be adequately addressing family concerns about breastfeeding. What do we know about why families choose not to breastfeed? Reasons for choosing to feed formula. Families think that formula feeding is easier. They may be more comfortable with the idea of formula feeding, so it makes sense that breastfeeding is discouraged during pregnancy when we make breastfeeding seem hard or schoolish. Focus on the advantages to the baby. Intervention. Normalize breastfeeding. Think about potential adult benefits due to lactation. For example, knowledge of breast cancer risk reduction may influence breastfeeding practices. Change fewer ear infections for the baby to you may have fewer pediatric visits for ear infections. Interact with people as though exclusive breastfeeding is the expected choice. How can I help you to breastfeed your baby? Women who decided not to breastfeed are not so much embracing this method of feeding formula as rejecting breastfeeding. Intervention. Positive experiences through knowledgeable peers. Confidence and empowerment increase with group-based peer counseling. Videos alone are ineffective. Peer counselors provide support, information, and social learning. Women's decision to breastfeed was found to be significantly associated with WIC peer counselor contacts. La Leche League provides support, information, and social learning through mother-to-mother support. Men think it's not natural to breastfeed. Men worry that breasts will get ugly. Study of breast changes. Mothers frequently report that the size and shape of their breasts have changed after childbirth, but these changes do not seem to be associated with breastfeeding. Studies of fathers report that breastfeeding separates them and others from the woman. Breastfeeding makes it hard for others to develop a relationship with a child and makes the father feel inadequate. We must address for fathers breastfeeding is normal, achievable, desirable. Breastfeeding protects from specific diseases and give lists. Breasts were made for breastfeeding. U.S. fathers are eager to learn. Good counseling is not like talking to a friend, a teacher talking to a student, mechanical fixing of what's wrong. Hands on increases the mother's sense of being a machine that can be turned on and off by others. Giving advice that would work for you. One size fits all information as found on the internet. Imposition of the counselor's agenda on the family. Breastfeeding counseling goals. Family concerns are heard and valued. Baby feels heard and valued. Counselor elicits the whole story before offering feedback or intervention. Adults, baby, and counselor are fully involved in problem solving. Safety is always a primary focus, even over breastfeeding. Technology and gadgets are used very carefully. Counseling process. Listen, gather information using questions that can't be answered with a single word. Listen, verify what you've heard. Listen, offer individualized information, not advice. Listen, work together to develop a plan. Listen, review and fine tune the plan. Listen, establish a follow up plan and make needed referrals. Summarize, listen, and document. Avoid loaded and judging words. ORS, step 2, motivational interviewing from Bershad. O. Open-ended questions. A. Affirmation. R. Reflective listening. S. Summarize and teach back. Ors. Open-ended questions. Show interest in what is on the client's mind today. Ask questions that can't be answered with a single word. Start questions with how, who, what, when, where, etc. For example, how can I help you today? Or what would you like to discuss today? Why can be perceived as confrontational. Instead, try, tell me about. For example, instead of asking, why did you start formula with your breastfed baby? Try, tell me more about what led to supplementing with formula. Ors, affirmation. Build empathy and a connection between client and counselor. Listen for and call attention to examples of good actions or decisions to affirm. Strive for genuine and specific recognition, not a generic response. For example, how wonderful that you chose to trust your knowledge of your baby's cues over those who told you to feed every 3 hours. Or, you have been working hard to collect milk in preparation for your return to school. Ors, reflective listening. Listen for deeper understanding of the situation, hearing not only the words but open to possible underlying meanings and beliefs. Rephrase or paraphrase statements or reflect on the meaning of what you heard to assure understanding. For example, after hearing a pregnant woman has heard that other family members have struggled with milk production, you might say, "It sounds like you are wondering if that would happen to you also." Then ask, "Have I understood you?" Ors, summarize and teach back. Summarize strengths shared by client and action steps planned. For example, you've identified some strategies that will help improve your milk flow. Let's go over your feeding plans. Teach back. Ask client to demonstrate back a skill or learning. For example, after helping the client achieve more optimal latch on one breast, suggest, "It seems like baby may be ready to move to the other breast. This time, I'll be quiet and you position the baby for a more comfortable feeding." And then there is not a cutout, but basically a section here that says Miller and Rolnick's 3 definitions of motivational interviewing from 2013. Layperson's definition. Motivational interviewing is a collaborative conversation style for strengthening a person's own motivation and commitment to change. Practitioner's definition. Motivational interviewing is a person-centered counseling style for addressing the common problem of ambivalence about change. Technical definition. Motivational interviewing is a collaborative, goal-oriented style of communication with particular attention to this language of change. It is designed to strengthen personal motivation for and commitment to a specific goal by eliciting and exploring the person's own reasons for change within an atmosphere of acceptance and compassion. Greater support is needed for first-time parents, mothers of late preterm infants born at 34 to 37 weeks gestation, women with family or financial problems, women experiencing postpartum adjustment disorder, PPAD. 85% of women experience mood changes associated with hormonal changes, lack of support, and many life changes. PPADs are not related to feeding choice. Women with a history of premenstrual syndrome, PMS, and prior dysphoric disorder have a higher risk of PPD, postpartum post-traumatic stress disorder, PTSD. Up to 9% of postpartum women met the DSM-4 criteria. 2 conditions significantly increase the odds of postpartum post-traumatic stress disorder. Depressive symptom scores and total number of physical symptoms experienced since the birth. Is more information better? No. Recall is less when more topics are discussed. Therefore, limit the number of topics discussed at any one session. Communication that is centered on mother's concerns, not biomedical conversations, enhances information gathering and relation building. Support the desire to exclusively breastfeed. The optimal start. Babies born during the night and early morning had double the odds of supplementation compared to babies born during the day. At 1 month, the frequency of exclusive breastfeeding as well as behaviors that promote breastfeeding was significantly higher in the group that received a doula. Intrapartum synthetic oxytocin, Pitocin. Oxytocin or Pitocin infused during labor decreased the amount of oxytocin released from suckling on day 2 dose dependently, and is an independent risk factor for APGAR scores of fewer than 7 at 5 minutes and unexpected admission to the NICU lasting more than 24 hours for full-term infants. Higher relative risk of mother receiving a documented depressive or anxiety disorder diagnosis or antidepressant anxiolytic prescription within the first year postpartum than women without synthetic oxytocin exposure. What about pain medications during labor? Mixed result from studies. It's complicated. Mothers who have had labor meds need extra breastfeeding support and may have a delayed onset of milk coming in. Research suggests, avoid longer durations, delay administration of epidurals, conservative use of IV fluids, close follow-up and good breastfeeding support, continuous support in labor from a doula, reduce the need for pharmacologic pain management through Lamaze or other childbirth education, breathing and relaxation, hypnosis, acupuncture, acupressure, etc. What else can we do to support exclusive breastfeeding during the hospital stay? Implement the 10 steps to successful breastfeeding. Bags containing breastfeeding supplies or no bag at all were positively associated with exclusive breastfeeding at 10 weeks and 6 months. Weaning risk is greater when hospital practices do not support breastfeeding. A positive relationship was found between MPINC score and in-hospital exclusive breastfeeding, any breastfeeding, and exclusive breastfeeding at 8 weeks. Use quality improvement measures to identify and change unhelpful practices. The Joint Commission created a perinatal care core measure set for implementation beginning in 2010. The measure set includes 1. Lower elective surgeries, 2. Lower cesarean sections, 3. More antenatal steroids, 4. Lower healthcare-associated bloodstream infections in newborns, 5. More exclusive breast milk feeding. And look at the notes, the way they did it. Like, I just interpreted that the down means lower, but this is why you have to read some of these things, and you have to watch the videos so that you understand this in context. This quality measure anticipates that hospitals will implement a strict definition of acceptable criteria for supplementation and work toward 100% exclusive breast milk feeding. Step 4 of the 10 steps to successful breastfeeding. STS in the first skin to skin. It says STS, but you have to know that it means skin to skin. Skin to skin in the first hour and encouraging early feeding is one of the most powerful steps in influencing breastfeeding outcomes. Skin to skin is a good starting point in changing practices. Wickstrom et al. Found that all babies transition through the same 9 states. Cesarean birth, according to research, is a barrier to breastfeeding, perhaps due to later initiation of breastfeeding or more separation or more supplementation or greater weight loss. Better post-op pain control improves breastfeeding outcomes. The baby's gut microbiome is affected by antibiotic use, mode, and place of birth. Skin to skin after cesarean may increase breastfeeding initiation, reduce formula supplementation in hospital, and maintain infant temperature. If the mother is separated from the baby, the partner can do skin to skin. In a study of fathers, the infant in the skin to skin group were comforted. That is, they stopped crying, became calmer, and reached a drowsy state earlier than the infants in the control group. It says the COT group. In the control group. Common labor meds can affect whether the baby suckles in the first hour or not. When a mother has had labor pain medication, her baby needs at least 2 hours of skin to skin contact for the baby to self attach. The higher temperature of the areola helps guide babies to the breast. Smell is also an important early developed sense for most newborns to attract the baby to the breast. Exposure to the mother's odor may facilitate the infant's adaptation to the early postnatal environment. The mother's areolae and milk odor appear to be sufficient to attract and guide neonates to the odor source, especially after the infant has been exposed to the contractions of labor. Maternal breast milk odor calms newborns during painful procedures. Women are rewarded when they smell babies. Body odors of unfamiliar 2-day-old babies elicits activation in reward-related cerebral areas of women regardless of their maternal status. A delay in the newborn bath at a hospital that was already baby-friendly from 2 hours to 12 hours in the mother's room rather than the nursery with the parents participating and with skin to skin following. Skin to skin promotes decreased rate of primary postpartum hemorrhage, faster expulsion of the placenta, correct suckling, less crying, decreased rate of primary postpartum hemorrhage, faster expulsion of the placenta. They repeated this. Correct suckling, they repeated this. Less crying, they repeated that. Skin to skin babies are warmer. Mothers' breasts are warmer too. I'm going to cross out the repetitive because when you're reading things and it repeats, it makes you think like you've missed something. Skin to skin babies are warmer. Their mother's breasts are warmer too. Mothers with early skin to skin plus an opportunity to touch the nipple place their babies in the nursery for fewer minutes. When babies are in close proximity, families can observe for feeding cues. Babies can be held skin to skin. Babies can smell the milk. Babies can be fed at their best time. Learning happens together. Mothers whose babies roomed in slept slightly longer and reported a higher quality of sleep than mothers whose babies were in the nursery. Skin to skin promotes breastfeeding. Compared with mothers with no early skin to skin contact, exclusive breastfeeding was higher in mothers who experienced longer skin to skin contact. Women who had reported depressive symptoms in pregnancy, Edinburgh Depression Scale. Its EPDS is lower than 13, but that's EPDS is the Edinburgh scale. If they did not accomplish the first breastfeeding session within 2 hours after birth, had an almost fourfold increase in not exclusive breastfeeding at 6 weeks postpartum. Counseling implication: women reported depressive symptoms during pregnancy. Women reporting depressive symptoms during pregnancy seem to be more vulnerable to the effects of postponed first breastfeeding on exclusive breastfeeding. Women who have experienced depressive symptoms may benefit from targeted breastfeeding support during the first hours after birth. Risk of delayed breastfeeding in the hours after birth. Mother: lower prolactin receptors activated, lower oxytocin or uterine contractions, lower milk volume, lower opportunities to practice with colostrum, lower confidence, higher risk of supplementation. And then I'm just going to show you what that actually looks like. Baby. The baby, the higher risk of jaundice, sleepiness and lethargy, higher risk of hypoglycemia, lower opportunities to practice with colostrum, higher risk of supplementation, higher pH and opportunistic microorganisms in the gut. And that is the end of the reading for the 3A handout. Thanks for listening.